Well, hello, and welcome to the May edition of Let's Talk SADS. And I'm Shu Sanitani, and I'm coming to you live from Vancouver, and a little bit jet lagged. I just got in from a whirlwind trip in Europe, which sounds glamorous, but it did finish with some work of moving my daughter back home. And I'm a little under the weather as well, so forgive me if I have some coughing fits. But no, it was a great trip, and it felt almost back to pre-pandemic times in some ways. Uh, Not a lot of masks, not a lot of sort of there were crowds everywhere, and the world is slowly going back to normal. Um, That said, um, it was wonderful to be away, and but even better to come home. Now I've forgotten all my skills on the StreamYard here, so I'm gonna share. Um, I'm gonna try and share my picture here with you. All right, I'm fumbling around here. Where is it? There we go. Okay. All right. So on my first day in Europe, and hopefully you can see this. On my first day in Europe, and this is London Hyde Park, which is not far from Buckingham Palace, and I was out for a little walk jog, and I saw some people coming by me with SADS UK uh, shirts, and they were doing steps for SADS and a fundraiser. And this couple was kind enough to stop and let me play with their dog for a minute and pose for a photo. And it really felt like the world was very connected at that point. To have traveled thousands of miles and be right amongst the SADS community again. And that really is one of the amazing things about the SADS community is that it is international, that people are so connected, and these tragedies that we're trying to understand and reduce uh, and improve the care of really happen everywhere to people of all walks of life and all manners of circumstance. So our job really is to promote awareness and education, and the purpose really of this chat is to learn together. And so one of the things I've had some fun doing is my fun Canadian fact. And so I'm going to continue to do that. And and I've lost my window again. All right, let's go for my fun Canadian fact, and hopefully here it comes. And so, just a quick reminder, a review. We started with George Mines, and he was, of course, a pioneer in the field of electrophysiology, studied and worked at McGill. And Jenny Kidd Trout, who was the first Canadian female physician to be licensed, and John Hops, who really did a lot of the background work to make the defibrillator possible. And then Madge Thurlow Macklin, um, who was considered by many the founder of medical genetics, working in London, Ontario at the time. And so today's today's guest or feature story, and because I'm not in slideshow mode, you're going to see the answer right away. Is the first is the First Nations nurse to be uh, trained in practice. So this is Edith Anderson Montour, who was of the Mohawk Nation, and she also had to train in the United States to get her nursing qualifications, and then went off to war, World War One, and had a long career, and um, and is credited as being the first First Nations nurse. So Edith Montour. She also was somehow the first person to be able to vote, the first woman to get the vote, but that's a separate story. So back to the task at hand. So some of you hopefully will recall that last month, which feels like an eternity ago, we had a wonderful guest, a genetic counselor from Toronto, Melanie Kerr, and we really tasked her with walking us back to the basics of DNA and the definitions of variants and why we don't necessarily use the term mutation, and even just some basic concepts about how how we get how these SADS conditions arise. And so today we're going to continue that learning journey, and we're delighted to have Melanie back. So Melanie is the official first repeat guest on our SADS Live, and we're delighted to have her back to continue the conversation about now the next level of this conversation, which is all about genetic counseling. So um, delighted to have Melanie back in the studio with me.
Hi, I'm back. Nice to see you again.
Hi, Melanie. It feels like yesterday that we were talking, but it's already been over a month, and I'm so glad that we could fit this in just before May ends.
Absolutely.
And I really enjoyed our last chat because I felt like it took me and our audience right back to the basics of of life almost. How genetic material is passed from parents and how these spelling mistakes arise. And you used some great analogies to make it very understandable. And so today we're delighted to have you back and task you with really taking us to the next step, which is, in my opinion, is the one of the most important parts of the whole genetics of our field, is really to be informed users. And I
Absolutely.
think, the first thing I'll say is that the genetic counselor is uh, such a key such a key person in the team. And so one of the red flags for me is if
Mhm.
people are offered genetic testing without a genetic counselor uh, being involved at all. And I say this very hypocritically because in our program we don't actually have a genetic counselor full time. We work very closely with the adult genetic counselor, but
Yeah.
we don't have one on site. So, Melanie, take our audience a little bit back to the basics and just
Sure.
explain how does one become a genetic counselor?
Yeah, it's a good question. I mean, I have joked with some of my colleagues in the past that we're a member of the community of obscure healthcare professionals. There's not very many of us out there, to be honest. Getting more and more, for sure. We're increasing in numbers, but it's still a pretty sort of, when you think about some of the other allied health fields, you think about physiotherapy and occupational therapy and these sorts of things. And there's lots more of those kinds of people around than there are genetic counselors. And I think that's going to change over time. But it's still it's a small profession, and the training programs are still small, actually. So, to answer your question, genetic counselors are trained with very specific master's level science degrees. And so there are a number of programs across North America with specialized master's in science and genetic counseling programs. And it's very focused on clinical training. So we learn about, of course, all the basics of genetics, broad study in all kinds of genetic conditions and how things are inherited and how all the things we talked about last month, work. But then we're also sort of very cognizant, we're very aware of how we communicate that information to people, right? Genetics is complicated, medicine is complicated, science is complicated. And I think there's a real skill to learn about how to speak that language of science and genetics in a way that makes sense to people. And that's the whole reason that we exist, really, is to be able to do that and try and be like a translator, right? A translator of science and medical information, specifically in genetics, to people who maybe don't have those backgrounds. So it's a 2-year program. In Canada, actually, there are now currently, let me think about this. There would be 5 genetic counseling programs in Canada. Each accepts about 4 to 6 students a year. So it's small and it's specialized.
And does one have to have an undergraduate degree in
Yeah.
something different, a different science?
Yeah, most people I would say going into genetic counseling will have a science undergraduate degree. So an undergraduate degree, certainly. Some people come in from like a psychology background, but more often than not, people will come in from a biology, science, molecular biology undergrad specialty.
And and I think the term counselor also confuses people a little bit because they don't necessarily appreciate that it's a pretty rigorous scientific uh, training and background, and
Absolutely.
not really like the high school counselor that you're seeing when when you're trying to figure out what you're going to do after graduation.
Yeah,
So
absolutely there.
very important discipline. How tell us a bit about how does the family end up sitting in front of you, or the patient, or the parents, or the
Yeah.
children? How do they end up in front of you?
Yeah, they come. So there's many ways actually, but it is usually because families have been referred in one manner or another to either a genetics clinic, so like a medical clinic, either specialized in genetics, or a cardiology clinic. So for me, as you know, I work directly embedded within the cardiology clinic here at Toronto General Hospital. And so, when patients are referred to a cardiologist because of a question of whether they may have an inherited heart condition, or they themselves present with symptoms that could be suggestive of an inherited heart condition, that family might end up sitting in front of me as a part of their overall visit and their overall care through the cardiology team. So the cardiologists that I work with, of course, are doing, focusing very much on the clinical investigations and diagnosis and that sort of thing, and talking about what appropriate genetics or how appropriate genetic testing or genetic information may be. And then I also would then sort of come in either after or during to really drill down and focus on that genetic piece to help people understand what information they may or may not receive by going ahead with genetic testing, and what some of the benefits might be, one of the limitations might be, that sort of thing. And that's how they get there, is really through referral from a doctor for a specific indication of a possible inherited heart condition in themselves or their family member, really.
And so you're embedded right in the team,
Mm.
and so let's focus in a little bit on our area of interest, which is the SADS condition. So the sudden arrhythmia syndromes, and so let's talk a little bit about um, the one that we're quite familiar with, long QT
Sure.
syndrome. So long
Perfect.
QT syndrome is, to me, it's a nice example that a lot of people have heard. It's an electrical heart condition where your heart's electrical rhythm may not be that stable, and you can have dangerous arrhythmias. Now, the vast majority of people, of course, are just fine.
Yep.
So someone has been diagnosed with long QT syndrome and gets sent to you. Why should they or should they not have genetic testing?
Oh yeah, that's worth a good 15 minutes right there. But no, I think there are various reasons actually why people are offered and would consider having genetic testing. So I don't really like to use the terms like should or should not. I think physicians are a bit more use that kind of language a little bit more than we do in genetics. We kind of look at reasons why you might want to think about it, reasons about going ahead with it, reasons why you might want to think about considering it further before making that decision. So,
Sure, yeah, that's the jet lag talking, and of
I
course, yes.
think, well, no, I mean, it's fair. I think that's the language that's used with a lot of people, and that's where people come into my office with that notion as well. And I think there are misconceptions right from the get-go with people about what genetic testing can and can't do for them, right? I mean, I think at the sort of ground level, a lot of people come into this question of genetic testing as it's kind of like it's the be all end all. It gives you a definitive yes or no answer all the time. And that's what so many people will say to me is like, oh, well, I was told I should do genetic testing so I can find out if this is genetic, right? That's sort of one of the biggest, I think, misunderstandings to try and correct right from the get-go. So genetic testing, of course, is like we talked a little bit about last time, but just as a refresher, it's the process of analyzing specific genes for a specific condition, often to look to see if there are any differences, variations, something within that gene that impacts how it can do its job. If a gene isn't doing its job properly, that's when someone's going to have a genetic condition, right? So we're looking to see if we can find that genetic marker that's causing the gene not to do its job. When someone comes in for an evaluation, they're suspected of having long QT syndrome. I think that's another thing that people don't fully appreciate when it comes to medicine and diagnoses. It's not always black and white. You would certainly know that better than I do, right? And so, there's a lot of times that the physicians will say, we've done these tests, we're quite suspicious that it's long QT, or sometimes the opposite. We don't really think it is, but we don't know for sure. And genetic testing can help provide you and other cardiologists working in this with an additional piece of information that can either confirm that, yes, this is long QT if something definitive is found. If nothing is found on a genetic test, it can say, it doesn't exclude it. That's a really important point. Always, genetic testing can never rule out a genetic condition, but it can be put in the context of other clinical information from the cardiologist. Say, this all fits. We're less concerned. So I think that genetic testing does have the potential to really firm up a diagnosis in some cases. So that's one reason to consider having it for sure. The other thing that I think people need to think about, of course, if we do identify what that clear genetic cause is in a person who has long QT syndrome, we know definitively that their children, their siblings, their parents have that sort of concrete 50% chance of carrying that same genetic finding. And then the opportunity exists, it presents itself to very definitively be able to tell family members who want to know. And there's lots of reasons, that we can talk about why people do and don't, but we can identify people who maybe their ECG looks normal, but they have that genetic finding and we know they're at risk and we can treat them, the physicians can treat them properly to reduce the risk of these tragic events happening associated with a condition like long QT syndrome. And I think when we talk about why people should or shouldn't, but may or may not choose to have genetic testing, it's a different conversation for someone who has a clinical suspicion of long QT syndrome versus a family member who we don't know for like their ECG looks like uncertain or normal. So family members, unaffected people in a family, it's a different conversation than someone who had an event, right? Someone who had a fainting episode where this is clinically very suspicious of long QT syndrome. So, it's not a necessarily for every person, it's different why they might consider doing it or not doing it. And I think it's increasingly in something like long QT, it's a bit more straightforward than I think some of the other conditions we deal with also, because there are medical recommendations made on genetic test results sometimes based on the finding, if it's a clear-cut definitive genetic finding. And so I think we think about that a little bit differently than some of, even the other genetic conditions, something like arrhythmogenic right ventricular cardiomyopathy, which has different implications in terms of a positive genetic test result for family members than something like a long QT does. So it's kind of it's a convoluted little bit of an answer there, but I think there's people will take a look at the information that's given them and then take it from there.
And I think, we've started with, probably one of the conditions we understand the best, long QT syndrome. And we've seen how difficult the conversation can be, how nuanced it can be. I do think, and you and I weren't at the heart rhythm meeting, which just happened in New Orleans this month, but I know Mike Ackerman had some very exciting work about gene specific therapy. And so I think, the future is already here, where your treatment may be informed by
Yeah.
your genetic test results.
I mean,
And
certainly,
so
hopefully, right? That's where we want to get to. And I think that
that's
it
that
is coming.
that's the target. Yeah, that's
Yeah.
the goal line.
Yeah.
So
Although it's hard. And I do want to say, I want to jump in there for a minute and say, yes, it is absolutely the target, but it's also something that I think people need to recognize is not available yet today, right? So people do come in with an expectation that by identifying a genetic, or can come in with an expectation that by identifying what the underlying genetic cause of something is, means that we can fix it. And yes, ultimate goal, 100%. And I heard a little bit about what Dr. Ackerman was talking about, but it's not something we can do right this minute, right? So I think that's important for people to know and manage those expectations around what the genetics can tell you.
yeah, we're very much in a proof of concept
Exactly.
phase and learning, lots of learning. Now, um, now I've heard, and you touched upon this. Some people they're concerned, if they get the genetic test,
Mhm.
it's going to affect their employment or
Yep.
their in life insurance. And are there some protections around that or
Absolutely. Yeah. I think then again, this is a different conversation today than it was even 5 years ago, to be honest. Because, and again, different for someone who has a clinical known diagnosis of an inherited heart condition, as per someone who may be at 50 or 25% risk of having that, but have no cardiac features or symptoms, right? Those are two different conversations. So, at this point in time, regardless of what, I mean, if you have a clinical diagnosis of a heart condition, that's much more important to an insurance company always than what the underlying cause is, to be honest. For someone who's a relative, that was always the concern, right? If I have this genetic test that shows I have a pre existing condition, is that going to be used against me when I apply for life insurance? Will that affect my ability to get life insurance? Will it impact the premiums I have to pay? Those sorts of things. And I think they were legitimate concerns. Fortunately, in Canada, a number of years ago, a few years ago now, I think we're going on 4 actually, Canada instituted what's called the Genetic Non-Discrimination Act, or the GNA. And what that means is that by law, insurance companies are not allowed to utilize genetic information to assess insurability. Now, it means that they can't pull it from a health record. They can't ask you on an application about a genetic test result specifically. So that I think has been very comforting, reassuring for people. However, I mean, I'm always a little bit, I think it's important to continue to be thoughtful about that to some extent, because that law does not include family history information, right? So if you have a family history of long QT syndrome, genetic test results or not, that's part of your family history. And insurance adjusters will know that that's a genetic condition. So, it's the genetic testing will play a part in the insurance question. It's not the only part. And I've always, tried to be balanced in that as well when it comes to, this big fear of genetic testing in the context of insurance and potential insurance discrimination. When there are other factors that play into that too. But, back to, fortunately in Canada now we have a law that places that information under a protected status, which is nice.
yeah. But as you say, and this sort of prompts me to talk about my view of, you know, mostly I think genetic testing should be viewed like other very complex tests where
Absolutely.
you should know what the results are going to be before you even uh, trigger it.
Absolutely.
And I mean, you may not know the exact result, the genetic variant or whether that, but you should really have a good idea of what you're getting into because,
Yeah.
as you say, the people already have the condition or the family history, uh, and the genetic test really just confirms what you're already working on clinically. There's a great couple of questions in the chat,
Oh yeah.
and
Please.
one of the questions is how can we speed up testing? And I'm gonna modify that a little and say, tell us a bit about these, these companies that sort of say, we get your whole genome, spit in a tube and send it off, and without really the genetic counseling part,
Yeah.
the direct to consumer genetic tests.
Yeah. So, I mean, I think there are actually two parts to that question. I do think, and I do think it's reasonable to address, at least in Canada. I think there's a lot of frustration around wait times to access genetic information, right? Access to genetic information is not a fast process. The testing itself, I mean, from the time someone gives a blood sample to actually doing the like scientific analysis, that piece takes a bit of time, a few weeks to a few months, and that's just the nature of the beast. But there are some resource challenges in our country in people getting access to a genetics clinic, a genetic counselor, to be able to get that sort of pre-information or get to a place where they can make an informed decision about whether they want to do genetic testing. So that's an issue. That's a whole other conversation. But what that launches into is, I think it leads people down this path of, well, if I have to wait through a system that is taking a year and a half or 2 years for me to get to see a specialist who could provide this information, whereas I can go online right now, right, and order, I can spit in that tube, I can see what the result comes back, and then deal with it on the back end. With what that means is that for a lot of people, there isn't a great appreciation of actually what those results might show you when they come back, right, which can lead to misinformation. It can lead to, for the people and their family members, for that matter, it can lead to inappropriate accessing not the right level of care for them based on their results. Can lead to a lot of anxiety and fear without understanding what that result is looking at, that you're like what you're looking at in terms of that result. It's very easy to go down rabbit holes, right? Just like you order that test online, you can also go down the Dr. Google map like route and Google all the things about the results that you may have received, which may or may not apply to you as an individual. So, I think there's a real concern, to me anyway, about people misinterpreting a genetic test result when they haven't gone through the channels that involve the field experts and how they're going to actually interpret that result for you. Sitting in front of you. What does this mean for you versus what does this mean for anybody I look up on Google, right? Do you know what I mean? Does that make sense?
Yeah, no, absolutely. And I think, it's a good time to remind people that all of us harbor a number of very, bad looking genetic variants, or what are,
Yeah.
sometimes classified as pathogenic, meaning disease
Yep.
causing. And a lot of us have these variants that may never be expressed or may never
Exactly.
come to fruition. And so, the occurrence of those is much more common than the diseases. And this was a big learning experience when we first got excited about sudden infant death syndrome and
Mhm.
finding genetic variants and realizing that, wait a second, these, long QT syndrome, we say, is 1 in 2,000, but these variants were coming up, 1 in 500.
Mhm.
And so, the math just doesn't always add up. So,
Right.
always important
And
to remember.
and hugely important, I think, even for people where there's, a person who has a known like diagnosis of a cardiac condition, particularly in the realm of cardiomyopathies, right? Increasingly, we understand that not everybody that harbors a disease-causing gene variant goes on to get any sort of heart condition. And I think increasingly what we're realizing, and this is sort of often typically the way it goes, we don't have that percentage. I can't tell you if you carry disease, gene variant X, the probability or the percentage chance that you're going to get the heart problem, we don't have that number. But I think what we're learning is that it's not as high as we once thought. And there's literature coming out of a variety of sources. There's some great initiatives in the UK where they have large biobanks with actual clinical information gathered about people as well. And what we're seeing is that, at least for me, and I don't know if you think about it the same way, Dr. Sanitani, but I certainly appreciate this and explain this to people as, increasingly we're recognizing that for some of these conditions, these are genetic predispositions. It is a predisposition to this condition. It means we know we need to pay attention to you. We want to make sure that if something does start to change about your heart function or your heart rhythm, that we're looking after you, right? We're going to manage that so that we can, again, ultimately avoid sudden tragic events or people ending up in the hospital with extremely low heart function that has to be, really medically managed to bring back up, if possible. And many people that have these gene variants never go down that path at all, ever. And so, I think that the fear and the anxiety that can go along with having a genetic heart condition really needs to be balanced with that other side of things. I don't want you to ignore it. I don't want you to forget that it's there and think I'm going to be fine my whole life. I don't want that, because I want to make sure you're being looked after by a cardiologist. But I also don't want you to go down the path of, I'm going to have a cardiac arrest this week or next year, or I'm going to need a heart transplant, because that's not what we're seeing coming to pass.
Yeah, no, absolutely. And, a couple of other things are coming up in the chat that are very, very interesting and important concepts. One of them being the timelines of getting this, and also just the dissemination of the results. It's not in Canada. It's not a fast system. We've been struggling that ourselves. Let's talk for a moment then. So the genetic, you get this genetic result back, and it's not a slam dunk.
That's exactly the word I was going to use. I knew where you're going.
This is clearly it. But it's one of these gray zones, or what we call a VUS, or a variant of uncertain significance, or we just don't know exactly what to do with it. What's your approach generally? Like, maybe in your group, are you sometimes checking it out to see if it runs in the family, or what does one do then with this maybe?
Yeah, and I think that we need to sort of start by saying not all maybes are created equally, right? There's a huge category of result called uncertain or variant of uncertain significance. There's still a spectrum in there. And some of those variants of uncertain significance, a cardiology and genetics team can look at and say, they're calling this uncertain, but I have suspicion for a variety of reasons. And there are ways that we can go about trying to get more information, right? So first of all, we always have to ask, does the genetic finding that we identified in you match the symptoms that we see in you? Does it match what your heart rhythms are doing or what your heart function is doing? That plays a big role. And then, yes, look at other people if there's a positive family history. So if we find one of these uncertain variants in a family where there are multiple people with maybe not exactly the same, but similarities in their heart conditions, it can be very helpful to see if that variation tracks with that heart condition in the family, right? We call that, the fancy term we use is segregation studies. But really what we're looking for is to see if the gene variant tracks with the condition. If it does over a few people, it can't just be one, but like if there are a number of people in the family that all have similar heart conditions and they all have the same gene variant, then that provides us some evidence, right? It's all about building levels of evidence to come to a place where we feel confident that what we're dealing with is the right thing. Or alternatively, building the levels of evidence to tell us this is not it, right? So again, you can go the flip side of that. If you have two people in a family, and let's use a very clear-cut example again with long QT. It's not a perfectly, clean diagnosis always, but we can often see two siblings that very clearly have clinical evidence of long QT syndrome. They're brother and sister, so they share 50% of their genetic material. So we test one of them and we find this uncertain variant in a long QT gene. It's really, really, really tempting to say, oh, we found a variant in a long QT gene and this person has long QT. It must cause the problem. We have to be very careful not to do that. And for anybody who's been in that situation for themselves or their family, it's very important that you be careful with that information, because it's not always the case. And what we have found when we start to say, okay, two people in the family, they both have long QT. We found this uncertain finding in one. So we'll just test the other one because they have long QT. So it'll be the same thing. And then that family member does not have it, right? So if you have a variant in a gene and one person who has the condition in the family carries the gene variant and the other person does not, then we can feel pretty confident this is not what's causing this disease in your family, right? So that can be very helpful for us. Unfortunately, it doesn't happen all that often where there's nice, like clean cut diagnoses in multiple people in a family. Or I work in adult medicine and our team works in an adult medicine world, and families are spread out all over the place, right? Like we might see people, one branch of or one person in a family here, and never mind in Canada, they might have relatives in the US, in Europe, in India, who knows? Like they're all over the map. So when we have the ability to look at that, that can be really, really helpful. And I would always say to people who are going through this process of genetic testing, when you get a result from someone, and I hope you're, having an opportunity to discuss that with a specialist in cardiology and a genetic counselor, when they tell you they don't know whether this is what's causing your heart condition, please believe them because it's so easy to think, no, it has to be. But we've learned from experience. Uh-oh, I went blank. What happened? I'm back.
Oh, there you go.
Okay, what happened there? That was crazy. Sorry about that. I must not have been touching my computer enough. Anyway, could you still hear me?
Yep.
Yeah. Okay. So I would just say, like, please, like, we got to believe each other in that way, because over time we might learn more and we might be able to tell you, yes, this is, but often we also go the other way and say, this actually isn't. And we don't want anybody hanging their hats on that one genetic uncertain finding, because we don't want to overlook something else that might actually be the true cause, right? It's I wish it was a black and white and we could always give you the yes or no answer, but we really can't.
And that, that raises a lot of points. One thing that's been raised in the chat again is you've had a genetic test, 10 years ago.
Mm-hmm.
Do you need to update it? Have they, we are always hearing about people are discovering new genes for, this and that.
Yeah.
Are we really discovering new genes, or are we?
Yes, I would say yes. Yes, we are. Now, not every gene that gets reported as a new discovery actually turns out to be legit, right? For lack of a better word. And I think there's some really important things in that realm too. But to answer or to speak to that question about repeat genetic testing, not everyone that had genetic testing 5 years ago needs repeat, or 10 years, let's go 10 years ago needs repeat genetic testing. I think that it's very individual specific, but there are a lot of people with very clear sort of, we really think there's something genetic happening here, and we never found anything in that genetic test 10 years ago. We would certainly update that genetic testing. Two things are happening simultaneously. Number one is that we're discovering new genes, right? So there are definitely people that I met with 10 years ago who either got an uncertain result or who got negative genetic test results. And I look back at their genetic test report and I can count on it takes me two hands to see the number of genes that weren't analyzed that we now know are important players in this field. And we are finding answers for families by doing this. So that is one thing, is that this, it's not an explosion. Like I think we sometimes think about genetic knowledge, but they are slowly but surely new genes being identified that cause these. The other thing that has happened in the last really 10 years is that there's been, I would say 10 to 12 years, a pretty seismic shift in the technology. And so there was a big change in actually the technical aspects of how we do genetic testing and how we look for certain types of genetic change and genetic variants. And genetic testing 15 years ago wasn't as good at finding certain types of genetic changes that now we know are players in this field. So I think that it's not a one size fits all answer. Not everybody that had genetic testing 10 or 15 years ago needs repeat genetic testing, but I think everybody that has should ask the question of their care providers, right? Of their cardiologist and genetics team. Is this still is this result still applicable? Do you feel that there's more that should be done? And if somebody says that there isn't, there probably isn't, because I do say that to some people sometimes, but there are lots of times that it is relevant. So it's an exceptionally good question to ask whenever you are seeing your sort of cardiologist for ongoing care.
Yeah, no, absolutely. And back in our discussion, you raised another point that I wanted to make sure our audience understands. These families that are spread out everywhere. Um, I always sort of chuckle to myself when someone comes and says, "Well, it's in the file," or my aunt Mary, she's in in New Brunswick, but it must be in her file. Can you see her file? And healthcare is very disconnected, and so when we turn to the family and say, "Well, you need to send a letter to Aunt Mary's
Mhm.
doctor to explain this," and all the clinics that work in this space are very happy to do that. Um, but ultimately, we have to rely on the families to connect themselves.
Yeah.
Uh, Even though I know they see us drawing these charts and drawing these huge family trees, ultimately it's the someone in the family has to take the leadership to do it.
And it's a
Now,
partnership, right? It's a partnership between the family and the inherited cardiac team across all of, wherever these people are located. And I think that that's an important point to get across. We're going to do our best to get what we need for you, and we're going to ask you to help you, right?
yeah, and Margaret's just brought up in the chat the importance of communication back to
Hmm.
the family physician, a rare breed, the family physician. Now,
Hmm.
as being sometimes left out, and who is in fact, especially in the smaller places, who is actually the family doc for many of them.
Yeah.
Melanie, I could sit and talk to you for a very long time about all of these things. We've barely scratched the surface here about the
True.
genetic counseling. Um, I think we're going to have you back because because it's just such a pleasure talking to you, and you know, and there's important things, important questions. You know, my I people know I'm a pediatric heart rhythm specialist, but I've been practicing long enough that some of my patients are having children,
Hmm.
and we've got to talk about pre conception family planning and things like that. So
Absolutely.
um, keep your um, keep your calendar open for another conversation.
Right on.
And I want to really thank you on behalf of the Canadian SADS Foundation for not only coming and chatting with me, but also just the work that you're doing every day in helping families navigate what is actually an extremely complex part of what we do, and you make it very real. So thank you so much.
Oh, thanks for having me. It's great to be here.
Wow, what a great conversation to have, and I always enjoy how Melanie frames the conversation, because she's right that the doctor sometimes is a bit of a thou shalt, or you should, and it's good to be reminded that these are important conversations and challenging decisions. So um and I think this we're coming to a close here. It's good to be back in back home, and this the Canadian SADS Foundation is in a bit of a a reinventing ourselves, and I'm excited that this is part of it. and I keep joking that I'm just auditioning for this role, but while they're still having me, I'm enjoying it, and we do value your support. We're going to have some exciting fundraising opportunities coming up later this year that we're working on in the background, and I'm definitely going to speak to some of those. Um, June is just around the corner, and June is always a crazy month for especially people with families and kids in schools and programs. But we're going to have a conversation about cardiomyopathy in June, and I'm really looking forward to it. And one of my favorite people will be coming. I'm not going to tell you who, and thank you so much for joining. And I hope I'm over my jet lag by the time I see you again. So thanks very much.